Okay, let's talk about elbow fracture, rehabilitation. Elbow fracture is going to have a lot of the same complications that a lot of our other fractures have in terms of just mobility. And as you know, we talked about with other fractures, if we're getting them too late, mobility can be the biggest problem. So this is going to be the case with the wrist and hand. This is going to be the case with the shoulder and with the elbow. So when we talk about elbow fractures, we have to remind ourselves of the anatomy of the elbow. And remember that there are three different articulations. There's the joint essentially between the humerus and the ulna, which is the one we think of the most because that does flexion and extension. But then there's also the joint between the humerus and the radius. And then there's the proximal radial ulnar joint as well. So those all three can be affected with a fracture, and it really is dependent on where the fracture is. You also have to recognize that there are two important ligaments, the medial collateral and the lateral collateral ligaments, that can also be affected, especially with significantly traumatic elbow fractures. So basically, the fractures are going to be classified in three different areas. You can have a fracture of the distal humerus, you can have a fracture of the proximal ulna, and you can have a fracture of the proximal radius. So you'll see that distal humerus is the fracture on the right, the top right. The proximal radial fracture is that middle top one, and then the bottom one is the proximal ulna fracture. Usually these are going to occur because of a trauma, so it's usually a fall, putting out the hand. The patient could have fractured, the wrist, the distal radius, the proximal radius in this case, the elbow area, or the humerus, the proximal humerus. So any of those things are possible. In this case, they fractured the elbow. And so the x-ray obviously is the most obvious way to figure out if there's a fracture, but there can also be swelling and some point tenderness, especially at the radial head. So if you think about it, the radial head is kind of the most exposed. It's the smallest area that can move relatively easily. So even if you don't have a fracture of the radial head itself, just by pressing there, you're going to be moving a lot of the elbow joint, and so that can definitely affect that palpation. It could affect any type of fracture. Pain with range of motion makes sense. The pictures here, the far left is going to be a fracture to the distal humerus. That middle one is a fracture to the radial head, and then the one on the right is a fracture to the proximal ulna. We can classify fractures, and in this case, the fractures of the elbow, type 1 fracture. This is called the Mason classification system, and a type 1 is going to be non-displaced. It's generally small hairline fracture. This type of fracture, we're not going to really usually do surgery for this one. Type 2, there could be a little bit of a displacement in the bones, but it's going to be around 2 millimeters or so. So not a significant amount of displacement or movement between the bones. They may or may not choose to do surgery with this group. Type 3 is where there's multiple fragments of bones. So this could be multiple bones involved. It could be that there's a fracture of the distal humerus, proximal ulna, radial head. That could be true. Or it could just mean that there's a significant amount of breakage in one of those bones. And so usually surgery is going to be required. There's also that possibility that the ligaments or other soft tissue were damaged with a type 3. And then with a type 4 fracture, you're likely going to get a dislocation. So with a dislocation, you're definitely going to have ligament damage. And so you probably need to consider that there's going to be a lot of different tissue, not just the bone, involved when you're doing your rehab. Elbow fractures, 7% of all injuries to the elbow are going to be a fracture. In children, they're most likely to have a supracondylar fracture. And you can see that here. So that's going to be a fracture of the ulna, the proximal ulna, and the distal distal humerus. But with adults, we're most likely to fracture a radial head. So you have to keep that in mind. Remember, when we talk about arthrokinematics, the radial head is going to be spinning with supination and pronation. So it's really, really the most important part of getting our supination pronation motion is that spinning of the radial head. So if there's a fracture, then that's obviously going to affect our supination and pronation the most. But if the fracture was in the distal humerus, proximal ulna, that's our hinge joint of the elbow, right? So that's going to be affecting our flexion and extension the most. Surgery, as I kind of said earlier, is typically not done for type 1 fractures and usually if type 2, as long as it's lined up pretty well, and there's just a couple of millimeters of movement, then they're probably not going to do surgery. And so instead, they're going to do just some sort of immobilization, and then we're going to do kind of conservative care. Conservative care is going to look pretty much exactly like our post-operative care once they're allowed to start doing mobilization. It's probably going to move faster than our post-operative care, but it's going to look the same. Type 2 to type 4 fractures are the ones that are more likely to have some sort of surgery, usually fixation surgery. However, if the fracture is bad enough, and especially if the radial head is like completely shattered, which can certainly happen with traumatic injury, then they may have to use an arthroplasty. So they may actually have to replace the radial head. So I've got some pictures here of those different surgeries. That top one on the left shows you where they actually replace the radial head, because in that case the radial head was damaged so badly that they couldn't fix it. But then the top picture on the right will show you where they were able to save the radial head. They just needed to do some sort of fixation. In this case, it was a couple of screws and one plate around the radial head. So again, that's going to affect their ability to do supination and pronation. The bottom left picture shows you a fracture of the distal humerus, and then a huge amount of hardware put into that distal humerus. We've got plates and screws. And then the last picture, that group of pictures on the bottom right, is showing you the distal, the one in the middle. Sorry, not the one on the bottom right, but the one in the middle is showing you the proximal ulnar fracture. So you can see a lot of hardware just around the ulna. You'll see the radial head is intact, the distal humerus is intact. So the only thing that's not is the ulna. And so really with a surgery like that, it looks a little crazy, but you should be able to get movement relatively quickly because only one bone was affected. If you look to the picture on the far right now, the bottom right, you'll see that this patient had both the radial head and the proximal ulna fractures, and so they had to have an arthroplasty of the radial head and fixation of the proximal ulna. So that one is going to be that's going to be more complicated rehabilitation. So what are our complications? Infection can happen. Hardware failure, especially if there's a lot of hardware. This is one where they may take out the hardware if there's significant irritability and pain. But the biggest problem that we will see is loss of range of motion. And this picture might look familiar if you did Module 3, because in Module 3, I did a whole slideshow on heterotrophic ossification. If you listen to that one, you will remember that, unfortunately, in the elbow, we can get this interesting complication that we don't get anywhere else in the body. And nobody really understands why. But basically what happens is after some sort of trauma, fractures, it's very, very common, but things like burns and other types of trauma to the elbow, when we go through that inflammatory process, the body decides we're going to start developing more bone, more ossification of the soft tissue around the elbow. So this ossification usually can actually be seen in an x-ray within the first, usually like 3 to 4 to 5 weeks after the elbow fracture. So after the fixation, that ossification starts occurring within a couple of weeks. And that, of course, that bony growth that's going to end up in the soft tissue around the elbow is going to limit their range of motion. So this is a complication that we have to be very aware to look out for. And again, an x-ray can start showing it relatively early, even if they're not demonstrating pain. So if you remember, we talked about ossification occurring, and patients may not have pain or irritability related to that ossification right away. It may be weeks later that they start to have irritability, maybe some swelling, inflammation. Those things there is occurring weeks after the ossification has already started. So if we're seeing range of motion limitations, especially where it feels very bony, so if you think about it, when you do elbow flexion, that's a relatively kind of springy end feel, like it bounces back. Extension should feel relatively hard, right? When we do extension, it should feel like, okay, I'm hitting bone to bone. And so when we do passive range of motion, it should feel that way. But with flexion, it should feel soft. But if you look at that picture there, if that ossification is happening along the anterior aspect of the elbow, when you go into flexion, it's going to feel hard. It's going to feel like bone is hitting bone, because that's essentially what's happening. So this complication is something you must consider with patients after elbow fracture. Again, it can start early. It can start within a couple of weeks. And so if you are seeing patients during those couple of weeks and their range of motion is becoming more and more limited, you might want to be concerned about ossification. If you're seeing them several weeks or months after the fracture, after the injury, and you're seeing them for the first time and there's just everything is hard end feels, you might say, uh-oh, this is ossification, and then we need to go get an x-ray to see what's going on. So not just related to ossification, but related to the surgery in general, it is important that the therapist knows how rigidly the bone has been fixated and what bones obviously are involved. So we need to know which bones, what area was the fracture, how much did they need to fixate those bones. We also need to know if other soft tissue was involved. So we're going to talk a lot about this kind of thing when we talk about tibial plateau fractures. It's really important to know, okay, with an elbow injury like this, just like with a knee injury, oftentimes ligaments and other soft tissue can be damaged. So with this elbow fracture, was there any damage to ligaments? MCL, so medial collateral ligament, is the one that tends to get damaged the most. So, did that occur during the injury? Is everything else with the joint okay? Some surgeons will also suggest sticking with what we call kind of a safe arc of motion. So we talked about this when we talked about other tendon issues at the elbow, that they may say, we just want you to stick with a certain arc of motion during your rehab. Because maybe it was such a complicated surgery and we're worried about soft tissue, we may have you do your range of motion from 30 degrees of flexion to 100 degrees of flexion. So just stay within that 70-degree range. Don't try to get full extension. Don't try to get full flexion. You may hear that. That might be something that the surgeon is saying we have to be a little bit more careful with that range. And that's normal. different than the knee, right? So with the knee, we're always going to try to get knee extension, full extension. That's so important after any type of knee surgery. But with the elbow, sometimes we don't want that initially because it's very dependent on the surgery and the hardware that was put in. Okay, so our first phase for this particular patient population is going to be 0 to 4 weeks, pretty common for the protected phase. And actually in the first week, we just want to make sure we're protecting that fracture site, making sure there's not a lot of irritability, making sure that the shoulder, the wrist, and the fingers are moving well. This is really important because, again, they're probably going to be in some sort of cast or something, hopefully not a hard cast, but something that, some sort of brace. And so they're not going to want to move that arm at all, but the shoulder really, really needs good movement during this time. So we're not going to be doing a bunch of, obviously, active range of motion at the elbow, but the shoulder should be moving. We know that adhesive capsulitis or some sort of issue with range of motion at the shoulder can happen within, 2 to 3 or 4 weeks. So, within that time period, we have to be careful of the elbow, but we don't have to be so worried about the shoulder. So you need to make sure that we're watching the elbow, but we're moving the shoulder, okay? That shoulder movement during the first couple of weeks is so important. And obviously wrist and hand too, doing wrist and hand movement within, in a neutral position of the elbow. So again, supination, pronation, you have to be very careful if the radial head was involved, but you can certainly move the wrist and hand. So we're going to be doing pain control things. Hopefully they're going to be using some sort of splint and sling and not a hard cast. You're not going to be weight bearing on the hand, obviously, during this period of time, or weight bearing on the elbow. And then you're starting to do passive range of motion at the elbow. So you can do active and active assistive range of motion at the shoulder, but only passive range of motion at the elbow during this first week. So when we talk about flexion and extension, again, you want to think more within an arc of motion. You are not going to try to push full extension during this first phase, especially during this first week. You are kind of thinking more like 30 degrees to maybe 100, 120 degrees of flexion to extension. So the extension, again, is about 30 degrees of flexion. For supination and pronation, the goal is to get to about 50 degrees of supination and 65 degrees of pronation. But I mean, again, if they've had the radial head fracture and fixation, you might be going a little bit more slowly with those motions initially. What's also interesting to recognize is that the MCL, so that medial collateral ligament, when you go into flexion, is more tight than when you go into extension. And so if the MCL was damaged, you have to recognize that you have to be a little bit more careful when you're going into flexion. And you also have to keep that MCL in mind if you're working on, MCL in mind if the MCL is intact, but they're limited in flexion. So don't push flexion if the MCL was injured. Do push flexion and think about the MCL being tight if the MCL was not injured. I hope that makes sense. So first phase, the first 4 weeks, they're usually going to put a brace or a splint on for 2 to 4 weeks, depending on the stability. So again, if it was just one bone that was fractured and it's relatively stable, they may just go for 2 weeks. If there was multiple fractures, they may go longer. We are starting with that passive range of motion. Again, just passive range of motion of the elbow during the first week. But as we move into week 2 to 4, you can start doing more gentle active and active assistive range of motion at the elbow. So we're going to be doing elbow flexion extension and then pronation and supination. And you can also start, again, second to third week, start doing some isometric. So all of those movements at the elbow, flexion, extension, pronation, supination. You see a picture there of the flexion and extension. So you can do all 4 of those movements in isometrics. I will always say kind of start at like 50% contraction. Don't have them push as hard as they can initially. See how they feel, make sure they don't have pain, and then you can always increase that resistance. But start at 50% or less initially, hold for 5 seconds, sets of 10. Definitely do gripping exercises. So again, try to keep that wrist in neutral supination, pronation as much as you can, but work on grip with that positioning, and teaching them how to do range of motion as home exercise as much as possible. So really kind of helping them see the importance of that gentle active and active assistive range of motion. So these are pictures of just some range of motion ideas. They can certainly do like an extension stretch. Again, as long as the doctor doesn't give you different restrictions for that arc of motion. If they say it's okay, starting at the second, third week, you can start doing these kinds of stretches. When we've talked about other elbow surgeries, we know that the anterior aspect of the elbow has a lot of soft tissue. When it gets tight, it's very hard to get extension. So doing an extension stretch like this really just passively helps to stretch out that fascia, that connective tissue, to allow for better extension. And this is something you can certainly do, like I said, at week 3, 4. And then flexion stretch, same thing. Flexion, the soft tissue along the posterior aspect of the arm is not usually as bad, but you can certainly do a flexion stretch and then supination, pronation as well. With the stretching, we know that soft tissue is 30-second hold. But you can certainly hold it longer as long as there isn't pain. That's totally okay. Okay, so phase 2 is week 5 to 8, and it's during this phase that we really want to make sure we're getting full range of motion. And so again, this is going to be working, you can start working more actively here. We also can start doing a little bit of strengthening during this phase, but most of the focus is going to be on active flexion, extension, supination, pronation. You can do it standing, you can do it laying down, doesn't really matter. And then with the pulleys, if you listen to the shoulder fracture recording, I really like the eccentric idea with pulleys. You can do active motion at this point for the elbow, which is a little bit different with the shoulder, but you can do active range of motion. You just, when you go into that flexion position, you can kind of do that passively and then have them slowly go into extension, and then kind of bring them back up into flexion and then slowly go into extension. That would be your eccentric control. But you can certainly just kind of do any of those things with this particular situation at this phase. This is showing an elbow brace. If you are dealing with patients who are very, very, very stiff, which again, this is what we usually see in China, right? It's nice to get these timelines and say, oh yeah, during the first week I could do this after surgery. But we know that most of the time, none of us are getting to see the patient during the first week after surgery. So if you're getting them at 2 months, which is kind of where this timeline is, we're talking about that second phase right now, and that's at 2 months. If you're getting them at 2 months for the first time and their range of motion is just really bad, and you look at them and you say, oh gosh, this range of motion is bad. But when you test the overpressure or accessory motion, so you're chesting into flexion and extension, it's more muscle guarding, it's more muscle irritability, so it's not bony. It's not that bony end feel like you would feel with heterotrophic ossification. It feels a little bit more give, more stretch. those are the kinds of patients that might do really well with bracing. So this bracing technique can help patients. The research, this from JOSPT, or no, this is Journal of Orthopedic Surgery, 2010, showed that bracing can, increase range of motion by 45, 50, 60 degrees. So I would definitely consider the idea of using a brace for these patients, again, as long as you're not concerned about ossification, because the ossification could get worse if you're trying to do a real hard brace and the body's fighting it, it gets irritable, you get more ossification. So as long as you're not worried about ossification, I would say that a brace is a great idea. You can use the dynamic bracing where, they can tighten it and it goes into more flexion, or they can tighten it and it goes into more extension. There's lots of different bracing options out there, and I would certainly say that if you're at that point where you're just not making significant progress with their elbow range of motion, and when I say that, significant progress is, and you should be using a goniometer to measure this stuff. You should be getting like at least 10 degrees a week. And if you're going a week without getting 10 degrees of motion in either direction, then I would say you need to consider bracing. It's hard to say. We do a lot of, again, we're talking about the end of 2 months right now, so it's mostly healed, but not completely healed. So, if the radial head, is affected, then you can be really pretty aggressive with flexion and extension. So you could probably, if it's just the radial head and it's not the ulna and the humerus, you could do like wall hangs and different things at the end of this second phase, no problem, because it's not affecting the radial head, right? The radial head is not involved with flexion or extension. And then if you are dealing with a fracture of the ulna or the humerus, then I would say wait until maybe the end of the third phase, so maybe 3 months, before you start doing hanging and stuff to try to stretch out into extension. But you need to start getting kind of aggressive with these guys after about 2 months. So the third phase is week 9 to 16. So again, this is going to be like month 3 and 4 is the third phase. And with this one, we want them using their arm as much as possible. We also want to make sure they don't have any scars, they don't have that ossification happening. And we can really start doing more of the weight-bearing elbow activities during this period. So we obviously want to increase strength during this period as well as endurance. So lots of progressive resisted exercises. This is, resisted exercises for arms are going to usually involve some sort of closed chain type of situation. So either a push-up position, you'll see we have them in like, a plank position with arm movements. You could also have them holding like TheraBand or something and doing kind of quote unquote closed chain with those kinds of things. And then you can certainly do open chain, but make sure you're doing lots of closed chain as much as you can, as much as the patient can tolerate, and not just open chain activities. You may need to do joint mobilization. I will tell you that ulnar distraction for patients who are really irritable, ulnar distraction in different planes. So distraction, and we practiced this in my class. So doing that distraction in a little bit more flexion versus a little bit more extension can really help with pain control. And then radial head mobilization is usually pretty easy. So really making sure that radial head is moving really, really well, so that you can get better supination and pronation. That's going to be important. So that's kind of the manual therapy stuff that you're playing with. I will also do, again, a lot of stretching. I don't really do soft tissue work on the anterior elbow. I just do a lot of stretching to stretch and elongate that adhesive tissue, the tissue that just does a lot of adhesions along the anterior elbow. And again, exercises, weight bearing, non-weight bearing, lots of plyometrics, those kinds of things. Starting at about 4 months is when you can start getting back into your return to sport stuff. We don't see a lot of athletes that end up with fractures. Usually the athletes will end up with more of the ligament injuries and things like that, or maybe a tendon repair, that kind of situation, ligament repair. So there isn't usually a lot of return to sport that's necessary with this group. But, return to sport can usually happen at 4 months. So that's kind of where we can start getting them back to their sport-related activities. So that is elbow fracture. Most important thing to remember is figure out why their range of motion limitation is there. Is it bony? Is it ossification? Or is it just soft tissue that you can stretch through?